Okay, good luck.
Hi, everyone, and welcome to today's Journal Club. I'd like to thank IGCS and ISGO for their support to our Journal Club. Before we begin, I want to mention a few housekeeping notes relevant to the Zoom platform for today's Journal Club. We are recording today's session, and the recording will be made publicly available. Participants with cameras turned on may appear in the video recording. We ask that everyone please keep your microphones muted so everyone can hear the presentations. If you are having any difficulties or questions, please send a message in chat and our technical support will assist. We'll have time for Q&A and encourage you to submit questions via the chat function throughout today's session. And with that, I'm happy to hand it to Professor Fagati.
So hi, everyone, and welcome again. This month's lead article is the poly-ADP ribose polymerase inhibitors, PARP, in ovarian cancer, lessons learned and future directions by Dr. Giuseppe Caruso. So I'm pleased to welcome Giuseppe with us to join us. And Giuseppe, thank you for being with us today and sharing a deeper insight into the great article. I'm going to hand it over to you for a submission of the article.
Thank you very much, Professor Fagotti, for inviting me to join you on this Journal Club. I'm going to share my screen. Let me know if you can see it. Can you see my screen?
Yes.
Perfect.
Okay, so we are going to talk about PARP inhibitor in ovarian cancer. This is a very big topic, and so it is very difficult to properly cover it in just a few minutes. So I'm going to show you briefly a few slides just to get into the topic, and then we will have plenty of time for the discussion. And I will start with what are today the current options for the first-line maintenance in patients with advanced ovarian cancer. As you know, the main driver for guiding the decision-making is the mutational status. Bevacizumab and niraparib are indicated regardless of the biomarker profile. And so, as you can see here, you can always find these two agents as possible options in all the three scenarios, while olaparib is indicated in HRD-positive patients in combination with bevacizumab, and in BRCA-mutated patients either alone or in combination with bevacizumab. And what's important here is to underline that reimbursement policies may differ from approval indications and actually vary across countries. A key question is why we should prefer PARP inhibitor maintenance in the first line. And here I summarized at least four reasons. Very briefly, the first one is the efficacy. No doubts on that. We all know the updated overall survival data from the SOLO-1 and PALA-1 trials. Then the second one is that the first line could be the only opportunity for our patients to receive a PARP inhibitor, because we don't know when and how patients will relapse. Then we have also new regulatory limitations from the FDA as regards the recurrent setting for unselected, and here I'm talking about BRCA wild type patients. And finally, we have safety issues regarding the risk of myeloid neoplasias. So we have all these options, and we stressed the importance of using the PARP inhibitor in the first line. The next question is how can we choose the best option for each patient? And, you know, for BRCA mutated and HRD positive patients is quite simple because they should absolutely receive a PARP inhibitor as part of their first line treatment. And then we can discuss if it is appropriate to add bevacizumab in case of suboptimal response to platinum or high-risk disease. The question, of course, becomes more difficult if we are talking about HRD negative patients, or when the HRD test is not available, or when the test gave a borderline score. And here, waiting for new predictive biomarkers, we can say that the best predictor remains the response to platinum. We can assess it in different ways, as you can see here. And so if the response is to platinum is overall favorable, then we should prefer a PARP inhibitor. While if the response is unfavorable, then bevacizumab becomes our choice, especially if we are talking about high-risk disease. Apart from the mutational status, we all know that there are several other factors that we need to consider for personalizing our strategy. And I will not go into details, but very briefly, we should consider clinical factors that can identify higher risk patients, and also the presence of symptoms like ascites, where we know that the anti-androgenic bevacizumab is very effective. And then we should also take into account the patient preference regarding the route and the duration of treatment. So this is my last slide, and this is our proposed algorithm based on the current evidence. It represents the ideal scenario where we used a PARP inhibitor in the first line, and we know that the PARP inhibitor can impact on subsequent treatments, and not only on platinum-based chemotherapy, but also on non-platinum therapy and surgical treatment as well. And we know that the concept of platinum-free interval has several limitations, but we still continue to use it in clinical practice to guide our decisions. So as you can see, we have platinum-eligible patients that receive a platinum-based combination with or without bevacizumab. And here I want to say that we should probably rediscover the role of non-platinum interposition, especially after the first relapse, as this could be particularly effective after PARP inhibitor. And I know that the Gemelli Hospital, the Gemelli team published recently an article on this, on this issue, on the interposition of non-platinum agents. And I want to add just two brief statements on PARP rechallenge. This is still a big question mark. We had interesting data from the Oreo trial, we know it, and we still need more prospective evidence. And then we have the emerging issue of the PARP inhibitor beyond oligoprogression, and we already have some retrospective evidence suggesting that patients may continue to benefit from the PARP inhibitor if they are managed with local regional treatment, either surgery or radiotherapy. On the other hand, you can see here in red, we have the platinum ineligible patients who receive non-platinum single agent, again, with or without bevacizumab. And now we actually have another promising option in this setting. As you probably know, the FDA recently approved, granted accelerated approval for the antibody drug conjugate milvetuximab in case of folate receptor alpha positive disease, which is a very promising option because it has a completely different mechanism of action from PARP inhibitor, and so it can potentially overcome and escape PARP resistance. And then, of course, just a few seconds, I would like to say that there are several clinical trials ongoing that are currently investigating the use of alternative agents that target different pathways than the DNA damage repair. And PARP combinations with these agents will hopefully help us to overcome PARP resistance and improve the outcomes. So that's it. This was a very brief review of the paper and the state of the art of PARP inhibitor in ovarian cancer. And so thank you all for the attention. And now I would leave room for discussion.
Thank you very much, Giuseppe. This was a wonderful summary. And we now will spend the remaining time on answering questions and group discussion. So we are all encouraged to submit your questions via chat function. And we will do our best to address all the questions that we can. So we are going to start with some questions from our fellows. So I see Andrea is ready for the first question.
Thank you, Giuseppe. Thank you very much for your kind, very, very good presentation. I would like to ask you, what is the most important take-home message of your review?
Yeah, this seems a simple question, but actually there's a lot on our plate, so it's not very simple to answer this question. I would say that stressing the importance of using the PARP inhibitor in the first line is crucial. And this is for all the reasons that we discussed before. It's a great opportunity for our patients. And thanks to PARP inhibitors, we have seen unprecedented survival rates in ovarian cancer. But I would also like to add another important key message, that is that we still need to understand so much about PARP inhibitors. You know, we started a few years ago in the recurrent setting, then we shifted in the first-line setting, then some of the things that we thought we knew in the recurrent setting are now being revised. So PARP inhibitor landscape is constantly evolving, and there are too many unexplained issues. And I also think that the slides that I've just presented will be old in a few years, because it won't be sufficient to just say BRCA mutated or HR deficient patient. We need to specify the exact type and location of mutations. So as for now, we can say that the take-home message is let's use PARP inhibitors in the first line whenever possible, and then let's wait for more data to guide our decision-making after the progression to PARP inhibitors.
Very clear. Thank you, Giuseppe. I think this is a very important message, as you said, and then we may go through more details, I think, during the discussion. Let's see what are the questions, and then we will see. So the next one is Nuria.
Yeah, hello, everybody, and thank you for the presentation. And yeah, the next question would be, given the controversies surrounding the definition of high risk and low risk ovarian cancer due to the high mortality from the disease, how does this impact on where PARP inhibitors fit in the management of ovarian cancer? Yeah,
well, Professor Coleman perfectly explained this in the editorial. I don't know if you had the chance to read it. The stratification in so-called low risk and high risk should be only hypothesis generating, and we should be very careful on not to misinterpret data when we look at clinical trials. As you know, the definition of high risk disease refers to the ICON 7 trial, where bevacizumab gave a significant benefit in terms of overall survival in these higher risk patients, that are those with stage 4 residual disease, neoadjuvant chemotherapy, and inoperable disease. I would say that the only scenario in which, if the patient has these high risk factors, could be useful is when we need to decide whether or not to add bevacizumab in BRCA mutated and HRD positive patients. Because here, of course, we use the PARP inhibitor, but we still don't know if the addition of the bevacizumab to olaparib gives a benefit in this setting. We know that there are several ongoing trials that are exploring this issue, and we know that we didn't have the PARP alone arm in the PAOLA-1 trial, so we actually don't have this data for now. So we will wait for the results, but in the meantime, it is reasonable to consider adding bevacizumab in case of high-risk disease. On the other hand, the definition of lower and so-called higher risk patients does not help us in the HRD negative patients because current evidence suggests that it's the response to platinum that should guide our decision. So if the response is favorable, we use the PARP inhibitor, and this is even in the case of so-called high-risk disease. And on the other hand, if the response is unfavorable, we use the bevacizumab regardless of the risk. And so this is even if the patients have not these high-risk factors. So this is what I think about the definition of high-risk disease.
Yes, this is clear, Giuseppe, and it's actually also how we do it here in Rome, more or less the same approach as you do. So I think the next one is Anita. Are you connected, Anita? I can see you.
Yes, I'm here.
Yes.
How are you?
Thank
you so much, Dr. Caruso and Professor Fagotti. My question is that now that we're in the era of targeted therapy, aside from chemotherapeutics, are the authors recommending that we shift in terminology to platinum eligible and not the platinum free interval, as the review notes that the latter might not be quite a guarantee to platinum sensitivity? And in future, does this mean that we might have a change in the temporal cutoff timelines? Thank you.
Yeah, thank you for the question. Yeah, absolutely. My answer is yes. I still remember the first time Professor Colombo corrected me on the terminology, platinum eligible and not platinum sensitive. As you know, the use of temporal cutoff, so the so-called platinum free interval, has been first criticized over a decade ago. It was 2010, and it was the 4th Ovarian Cancer Consensus Conference. And they already said that it is not an absolute predictor of the response to platinum, because the response actually falls on a continuum. So patients who relapse within 6 months still have a reasonable chance of responding to further platinum. And I would like to stress that the resistance is certain only if there is progression during the treatment. Otherwise, you can only suspect it. You cannot be sure that the disease is actually resistant to platinum. And on the other hand, a relapse after 6 months does not guarantee platinum response. And of course, all this issue is even more criticized in the targeted therapy era with the advent of PARP inhibitor, and this concept should be further questioned, because we know that the PARP inhibitor can impact on subsequent treatments, and so of course we have cross-resistant mechanisms. So we need to change the terminology. We should use platinum eligible and not platinum sensitive. And what I think is that in the future, we will not rely only on a platinum-free interval to decide our decision-making, but we will have new predictive biomarkers that will help us, hopefully, to understand, the platinum sensitivity and the PARP sensitivity. So we should change our terminology, yeah.
Yeah, so this is something that we need to keep in mind anytime we discuss cases at the tumor board, for example, not just not to be focused on timing, but on the chances to respond to platinum again. So before continuing with our fellows, I see there is a question from the chat. And the question is, what is the percentage of BRCA mutated patients on PARP inhibitors who are platinum resistant? The question is made by Vadaparthi Annapurna. I don't see you, but if you want, you can say it.
Yeah, we have 20% of patients in the SOLO-1 trial that still had an early relapse within 6 months, although they received the PARP inhibitor. You know, this is a very interesting question, because if you look, because we have, on one hand, we have these patients who are BRCA mutated, and we expect them to respond to the platinum and PARP inhibitor, but we can have the relapse within 6 months. And so these are the so-called bad BRCA, so 20% of patients. And probably what's behind is that we need to know what kind and what location the BRCA mutation has. It's not sufficient to say simply BRCA mutated patients, because on the other hand, there is also in the placebo arm of the SOLO-1 trial, there is 20% of patients who respond to platinum and had a good prognosis, although they did not receive the PARP inhibitor. And it would be very interesting to know which patients are these ones, because they don't even need maintenance treatment. So we should be able in the future also to understand when we can avoid maintenance therapy and so improve the quality of life of our patients.
So just following up your answer, Giuseppe, are you taking into consideration possible factors of resistance when you discuss these patients, or not yet? I mean, if you have, not only BRCA mutation, but the location of the mutation or additional mutations besides BRCA, so do you take them into consideration before considering maintenance treatment with PARP inhibitors, or is it too early?
Yeah, I think we are ready, but it's not, we are not ready in clinical practice, because as you know, there are several predictive biomarkers, and we are looking forward to use them. We can use the BRCA reversion mutation. There's the RAD51 reversion mutation. We have the amplification of the cyclin E1, that is another important biomarker. We also have the loss of the BRCA1 promoter methylation. Then there's the upregulation of the flux pump. There are a lot of biomarkers that are currently being studied. And some of these are very important because, for example, we know that the BRCA reversion mutations can be up to 20–30% of cases. So this is very important. but I'm afraid that we are not still yet able to use them in clinical practice. And so we still rely on platinum-free interval and on the response to platinum to decide the type of maintenance therapy. Now we use also the Kalim score, we use the BOM score, so the chemotherapy response score, but we have to wait for new data on these new predictive biomarkers.
Very good. Thank you very much, Giuseppe. So I see now Giulio is here with us. Giulio, do you have questions for Giuseppe?
Yeah. Hello, hi. Thank you, Giuseppe, for the presentation about the interesting topic. Well, my question is, the key role of PARP inhibitors as first-line maintenance therapy is now well recognized in general, at least in the BRCA and HRD patients. In this era of personalized medicine, are we ready for first-line chemotherapy de-escalation? What do you think about that?
Yeah, well, this is a million-dollar question. You know, the first time I heard about chemotherapy de-escalation was from Professor Coleman. I think it was the last ESGO Congress. He presented this slide that was, for me, quite shocking at first, but then actually inspiring. And he also talked about this interesting issue in his editorial. If you think about it, we have a big rationale behind treatment de-escalation. The benefit of PARP inhibitor in BRCA mutated and HRD positive patients is so striking and so evident that one might even think to use de-escalation approaches for the primary treatment. And as Professor Coleman suggested, we have at least 3 de-escalating approaches that we can think of. The use of PARP inhibitor in the neoadjuvant setting instead of chemotherapy. We can reduce the number of adjuvant chemotherapy cycles before starting the PARP inhibitor. And we can also reduce PARP duration. You know, we are starting also to wonder if 2-3 years is really necessary for all patients. So we need to discuss this more. And we have several early phase clinical trials that are currently investigating the feasibility of PARP inhibitor in the neoadjuvant setting, and we actually already have some data. I don't know if you know about it, but during the last SGO Congress, they presented the results from the NOW trial. You know, this was a single-arm phase 1 pilot study, just 13 patients, but quite impressive because these patients received 2 cycles of olaparib in the neoadjuvant setting and then underwent interval debulking surgery. And the surgical outcomes were outstanding because all patients received an optimal cytoreduction, and there was a complete resection in all these patients. And I would also like to stress that 20% of them were stage 4, so this is very impressive. And we also have trials in the adjuvant setting. Just a few seconds, I would like to share with you the N+ trial. I find it very attractive. It's a study that is currently exploring whether niraparib after chemotherapy in a very selected population with a favorable prognosis. So HRD positive patients optimally debulked after primary debulking surgery. So this is important. We are trying to see if niraparib can allow to reduce the number of chemotherapy cycles from 6 to 3 cycles. And again, this would be very helpful for our patients because it can reduce the toxicity and improve the quality of life. So I think that we are ready and that we will hear about treatment de-escalation in the future.
Okay,
yes.
Thank you.
Yes, Giuseppe, thank you very much. This is very important. I want to make a comment regarding the NOW trial that has been presented very recently. So these are very exciting results, in my opinion, but do not really fit with the 20% of the cases that you said are resistant to PARP inhibitors. So it's difficult to see. Maybe it's a case that all responded, but we need to keep in mind that there might be resistance, and this is the biggest challenge for us today. So I want to give, before continuing with our fellows, I see there are some questions from OnCare. The first one is that, what are your thoughts about oligoprogressive disease after PARP inhibitors? Do you think there will be a room for PARP inhibitors re-challenge after secondary cytoreduction?
Yeah, this is one of the most challenging and interesting topics, of course, in the PARP landscape. I do believe that we will continue to use, we will use PARP inhibitor beyond oligoprogression. You know, there's already retrospective evidence, and here again we have to thank the Gemelli Hospital for one of the 2 studies that I'm aware of, and it was a retrospective series, and these studies suggested that the benefit that the patients received a benefit from PARP inhibitor when this was continued after the oligoprogression, because you know, you can manage the single site of recurrence with the surgery or also the radiotherapy. We also have some data on radiotherapy. This local regional treatment can help us to remove those clones of cells that became resistant to PARP inhibitor, and then so we can continue the PARP inhibitor, and the rest of the disease was stable under the PARP influence. So I think that we will get there. Actually, I think that many of us are starting to do it in our clinical practice, although it is not a standard, because if we have one single site of recurrence, for example, in a BRCA mutated patient, it is a shame to stop the PARP inhibitor just for that site. We can manage that with the surgery or radiotherapy and continue the PARP inhibitor. So I think that we will get there.
Yeah, and indeed, I think that we should not talk about re-challenge, but it's really a continuum of treatment. It's not really a re-challenge, in my opinion. So following this discussion, I see there is another question from Pernil. I don't know, Pernil, you want to do it? I see you here.
Yeah, hi. Thank you for
Hi.
a great question. Hi, how are you? Yeah, so Giuseppe, thank you for a nice presentation. Do you hear me? Yeah, it sounds like, it looks like
Yeah.
Great. And you kind of answered some of my question. I just wondered, sometimes you have a patient who'd been on several lines. She was treated with carboplatin. You see that she did have response on most of her metastases, but some of them keep growing, right? So you suspect that there's a clonal differentiation if some of them. What do? Do you give her PARP? Do you remove the growing? Yeah.
You mean under the PARP
before, yeah.
treatment?
No, before, like if you want to give her, this is not maybe first line carboplatin, but after several lines, you want to give him PARP, but she has some metastases that do not respond to PARP. She is by definition not totally platinum sensitive. Yeah, what would you do?
You mean that she already received the PARP inhibitor, so you're talking about the challenge? No. So the first time you use the PARP inhibitor in a relapsed setting. Yes. Yeah, well, yeah, we need to be very, very cautious when we use the PARP inhibitor in the recurrent setting. We all know the overall survival data from the NOVA trial and the ARIEL-3 trials. So the FDA, as you know, in the case of the non-germline BRCA mutated patients, and in the case, so if you don't have the BRCA mutation, they withdrawn the indication for the PARP inhibitor. So I think that you need to know if the patient is BRCA mutated. If it is BRCA mutated and she didn't receive the PARP inhibitor, I would give it a try. But if we are talking about a non-BRCA mutated patient, yeah, I would be very careful, and I'm not so sure that the PARP inhibitor is the right strategy in that case.
Yeah, thank you, Giuseppe. Again, I think that here is a new place where everything is possible. I mean, we don't have experience in that, and we need to use our fantasy to do the best for our patients. So in this regard, I also think that radiomics can help, for example, to identify those nodules that will not respond. And in that case, probably either surgery or even radiotherapy can be helpful to remove the supposed resistance clones. So yeah, we have space for you know, inventing new strategies today. I would be in favor also to remove these nodules. I think it would be interesting. Anyway, we have many questions, so I'm trying to go through all the questions, and I'm sorry if I'm not taking all, but I will go back and look at them again. So the one I see here is that is regarding the accessibility to the HRD testing. What can we do as community to improve the widespread of the test? What about low-income countries? Do you know if there are homemade tests that can limit the cost?
Yeah, this is a challenging question. Yeah, I know. Well, in an ideal world, we should we need actually the HRD test, and we need it at diagnosis even before starting neoadjuvant chemotherapy, because we should decide if we want to add bevacizumab or not. So I know that not every center has the accessibility, and here I think that again, we should stress the importance of the centralization of these patients. I think that ovarian cancer patients should be treated in referral centers, because we need all these informations. If you don't have, I mean, I also depicted the scenario where the HRD test is not available, and you know, sometimes is also not conclusive in up to 18% of cases. In that case, you can still use the response to platinum. You can still rely on clinical factors to guide your decision making. And again, if you have the response to platinum, you prefer the PARP inhibitor, and in the other case, you use bevacizumab. So this is what I think you can do if you don't have the HRD test, or if it was inconclusive. So this is my opinion, and try to centralize the treatment of these patients. I know that academic research is doing a lot on this regard to try to have other tests than the myriad that we all know. But I know that the Gemelli Hospital has a great experience on this, but I'm not sure that we are already to the point that we can use them in every center.
Yes, Giuseppe, I have also another question for you. So you mentioned several alternative ways to measure HRD status. I mean, CRS score, or RECIST criteria, or the Kelly score. Sometimes it happens that these are not all aligned, you know, so you may have like a good Kelly, and then you will have a CRS score like 2, which is in the middle, or even 1. So you are able, of course, to resect this patient, but then you will find still a lot of disease. So is there like a scale or an algorithm on how to see what is more important for you? What is your experience in this regard?
Yeah, I think that we will have the answer to that soon, because I know that Professor Colombo is working on defining a score where you use a few points, 1 point or a few points to each of these variables, and then you get a result that can help you in deciding the strategy. So they are trying to validate this score, and I'm sure that we will have the results soon. Yeah. Okay,
very good. So I want to go back now for one question from the fellows, and I see that Ryan hasn't made a question yet. So Ryan, where are you?
Great, thanks, Dr. Fagati,
okay.
and Giuseppe, excellent presentation. Thank you for that. So for the roughly 50% of patients with epithelial ovarian cancer who will be BRCA wild type and HR proficient and won't receive a PARP in the upfront setting, what do you see as the most promising options in the future on the horizon to hopefully offer these patients that may have similar efficacies in the future?
Yeah, thank you for the question. Actually, what I think is that we should use a PARP inhibitor in the first line, even in the HRD negative patient, probably just with one exception, that are those patients who have an extremely unfavorable response to platinum, where it is probably better to use the anti-angiogenic. And I say this for several reasons. We already discussed about the importance of using the PARP inhibitor in the first line. So I want to repeat the 4 reasons that we already mentioned, but I would like to underline that it's true that the benefit of PARP inhibitor is less prominent in the HRD negative patients, but there is still a benefit. as you know, the PRIMA trial showed a 35% reduction in the risk of progression or death in HR proficient patients who received niraparib, and these results were also confirmed from the PRIME trial and the Athena mono trial. And another thing is that we should remember that the currently available HRD tests are not perfect. They are very useful for selecting the HRD positive patients who are ideal candidates for the PARP inhibitor, but they are not sufficient for ruling out the benefit of PARP inhibitor in the HRD negative population. As you know, the cutoff for HRD positivity is arbitrary, is conventional, and it also depends on the trial and the test you used. There are often borderline scores, and the patient may be regarded as HRD negative even for just 1 point. So you need to consider this before denying the benefit of the PARP inhibitor. So I think that we should use PARP inhibitor in first line even in these patients, unless they have an unfavorable response to platinum. And in the future, what I see for these patients is the combination of PARP inhibitor with the other agents. So the same strategy that we will use to overcome PARP resistance. So PARP inhibitor in combination with another agent.
Okay. I think this is a very important comment, because we must remember that approvals are different across over the world. So of course problems can be different, you know. So I see that this is a problem very important in the US. We don't have the same in Europe, at least in Italy. So it's important to highlight different perspectives. So continuing with our fellows, I see now it's the time of Guanza. I would ask Guanza, who never told.
Hello, everyone. Thank you for a very interesting discussion. So I wanted to ask, based on your review, what do you see as the most promising areas of the ongoing research into PARP inhibitors for ovarian cancer with respect of clinical practice and patient benefit? Like, what do you?
Yeah, I think there is, as I said, a lot on our plate. I would like to say that an unmet clinical need is to identify predictive biomarkers of PARP sensitivity and PARP resistance. The ideal dream is to be able to identify those patients who need only a PARP inhibitor, only bevacizumab, the combination of the two, the combination of PARP inhibitor with the other agents, or even nothing at all, as we said before. Because, as I said, there's these 25% of BRCA mutated patients in the placebo arm of the SOLO-1 trial who had a good prognosis without a PARP inhibitor. So we need to know who are these patients, and we need to know what kind and what location of BRCA mutation they have, so that we can avoid also maintenance treatment in these patients. Another promising area, as we said, is the chemotherapy de-escalation. It would be very interesting to reduce the number of chemotherapy cycles in selected patients. Another big topic is the PARP rechallenge, I think, and as Professor Fagotti said, the use of PARP inhibitor beyond oligoprogression. This is a very promising field. And another interesting point, I think, is also the role of surgery, Professor Fagotti, in the post-PARP era, because we always talk about medical treatments, but I think that there's a role also for surgery in this setting.
Yeah, indeed. In this regard, I would like to know whether you or anyone knows about new trials considering the role of secondary cytoreductive surgery after PARP maintenance. Is there anything on the plate or ongoing that you know?
Yeah, the only one trial I know is, I think, the SOC3 trial that is trying to investigate the role of surgery after PARP, but this was already in a relapsed setting. So the PARP inhibitor used not in first line, but in a recurrent setting, and then see the role of surgery after this one. I don't know if there are trials already in the primary setting. I think that we need it. We need a kind of desktop-3 trial in the post-PARP era. Also
desktop-4.
Desktop-4, yeah. This is an interesting idea, I think, because I think that the eligibility criteria could change. I don't know what's your opinion on this, but what I think is that the role of secondary surgery could be further reinforced in the post-PARP era, because if we say that we have resistant cells to platinum because of cross-resistance, then surgery can remove those resistant clones, and so the role could be further reinforced. And I think that the eligibility criteria could be also less stringent than the current AGO score. So I'm very curious to see what will happen to to surgery in this
Yes,
regard.
in this regard, actually, I was looking at your supplementary table on the rate of platinum eligible patients after PARP inhibitors, and I was looking at the rates in the PARP arm, which are a little bit higher with respect to placebo, but not so much. So at the end of the story, we will have a 10% increase of the population of platinum sensitive or platinum eligible patients who might reach the possibility of secondary cytoreductive surgery, although these are, again, results based on non-maintenance. So yeah, we need to study this new population. So we have few minutes, and we need to decide who give the space to whom give the space for the last questions. So there are so many still. I see there is one from Brenda. I think it's a long story. So maybe Brenda, if you want, we can talk together. You can send us an email, because I see that your story is quite long, and maybe then we can reply to you. Whereas I see there is a question regarding BRCA reversal. Is it documented by NGS? And then we can stop the treatment based on this. This is from Vada Party again.
Yeah, you know, we have some data from the Olympiad, the Solo-3 and the Light trials on the BRCA reversion mutations. And as I said, they demonstrated that they can reach up to 20–30%. But we don't have any data on how we should interpret this data. So I'm not sure we can give you some advice on whether we should stop or not the treatment. We need to have more prospective evidence on this, but I know that we are working a lot on understanding this, the restoration of the HR pathway.
Okay. And Andrea, you have another question, I know.
Yes. Thank you, Giuseppe. My question is, how do you think the decision-making algorithm you propose for the frontline maintenance can be refined in the near future? How do you place the complete molecular profiling of cancer at diagnosis in this context? And the following question is, how can the algorithm after PARP inhibitor progression be improved? Should we retest all these patients to understand what specific mechanism of PARP inhibitor resistance has been established and try to act selectively on this, or are we still far from that?
Yeah, thank you for the question. So as regards the first line algorithm, I think that several things will change. First, as I said, and I repeat it because it's very important, it won't be sufficient to just say BRCA mutated and HR deficiency. We needed to look into the type and location of BRCA mutation and HR deficiency, because you know there are bad BRCA, good BRCA. We have HRD negative patients who respond to PARP, and on the other hand, positive patients who do not. So we need new predictive biomarkers to identify the short and the long-term responders to PARP inhibitor. And of course, molecular profiling and translational research will help us. And I think that another thing that will change is that hopefully we will have PARP combinations for HRD negative patients, and hopefully we will have functional HRD tests such as the RAD51 assays that will help us to better select patients who will respond to a PARP inhibitor. As regards the post-PARP inhibitor progression, I think we have two big challenges. The first one is we need to further investigate the role of non-platinum interposition, and because the Gemelli Hospital published recently an interesting article on the use of trabectedin with doxorubicin after the PARP inhibitor. We know that data from the MITO-8 and innovation trial didn't demonstrate a benefit for this interposition, but this was the pre-PARP era. So now we need to explore this further in the PARP era. And as regards to the question on tumor biology, yes, I do think that we need to address this in a timely manner at each relapse, because we need to identify if the patient has a reversal mutation in order to personalize the treatment. And I also think that the liquid biopsy, I don't know where we stand with the liquid biopsy, but I think that this could be an interesting point to help us because it is less invasive and it can guide us at each relapse. So I think there's a lot going on, and hopefully we will have positive results.
So thank you very much, Giuseppe. This journal club has been really very insightful, and we hope that you enjoyed your time with us today. Thank you again, Giuseppe and the faculty for their time, and all the attending, of course. The recording to today's session will be available on the IJGC, the IGCS, and the ESGO website. And remember to join us on May for our lead article, which will be on ESGO, ESTRO, and ESP guidelines for the management of patients with cervical cancer, update 2022. So with this, I want to thank you all again and say goodbye. Thanks a lot.
Thank you very much.
Thank you. Bye.
Bye.
Bye-bye.
Thank you. Bye.